EMS has a spine board protocol change in your area, look at it a little bit more closely, because oftentimes what you'll find is that EMS will eliminate the log roll unless there's a few important things found. And those important things are a mechanism of injury that includes an axial load, neurological signs and symptoms, or a bony block that doesn't allow them to go to neutral position. So you and I, if we are going to activate EMS because we want to transport that person to the emergency room, why would we do that? We would do that because there's a mechanism of injury, there's pain in the back of the neck, or we have neurological signs and symptoms. So if you look more closely at the EMS changes in protocol, what you'll find is that there are changes in protocol for general accident victims so that they're not just backboarding everybody that walks out of a car crash. But in often cases, in our setting, their protocols don't really change much because their protocols still suggest backboarding under the three guises of which we are going to activate the emergency action plan to begin with anyway. Okay? So make sure that if you are looking at EMS protocol changes, that you go over that and you find out if that's the case. Make sure you do that beforehand. I just found this online. Look at this is an actual picture. This is not something that was rigged. A friend of mine who's a paramedic showed this to me. This is an ambulance gurney that rolled out of the back of an ambulance with a deceased person on it. So if they weren't deceased, they were probably going to be in short order anyway. All right. So when we look at long spine boarding, we look at some research has been done, long spine boarding versus putting somebody on the gurney, and that's kind of at the heart of this long spine boarding debate. Dr. Schwartz in 2016 produced a line of research that he's still working on actually, and he found that there was significantly less movement overall using a gurney only. So if we just pick somebody up and put them on the spine board, pick somebody up and put them on an ambulance gurney and transport them that way, there was significantly less movement than if we went through the whole transfer process on a spine board, which was pretty interesting. It does, however, require the log roll to reposition to supine. And it also requires a scoop stretcher to transfer or remove from the long spine board. I had mentioned earlier that maybe some of this debate is decided in real time based on how long you're going to have somebody on the spine board. But I also wanted to, if you go on our YouTube channel, there's a couple of video segments that we did that looked at the scoop stretcher, and because the scoop stretcher is an important part of this protocol of only using an ambulance gurney, of transferring someone to the ambulance gurney. So if we have a face-down athlete, we have to log roll them using a log roll technique, scoop stretcher them, putting them onto the ambulance gurney, and then taking them off to the emergency room. That protocol has been found to be associated with less movement than putting them on the long spine board. Okay? However, when we tested the scoop stretcher protocol on a football player on natural grass and on turf, the scoop stretcher is virtually impossible to work. There was a significant amount of movement associated with trying to get the scoop stretcher underneath an equipment-laden football player. Very, very challenging. In fact, to the point where I can't even recommend that a scoop stretcher would be a viable option in football. We then reproduced that same video segment on ice with a hockey player, and the scoop stretcher protocol was phenomenal. So much so that the first run-through that we did, the cameras weren't even ready in time. The scoop stretcher worked so fast and so efficiently that we didn't catch it with the cameras. We had to stop and redo it and reset the cameras because it was that quick. It was just slide together, click, and off they went. All right? So again, just goes back to the philosophy that I've been preaching all evening or all afternoon. We don't really want to make generalized recommendations that say under these situations we're going to do this every single time. It just doesn't work. And that's why we have that red kit philosophy. So if you, those video segments are on our YouTube channel, and they're accessible to you at any time. I think they're pretty interesting reviews, so check those out when you have a chance to. What's the expert opinion poll say about this aspect? Pre-hospital removal without trained escorts. So overall, when we talk to most people when we're doing our training, most will support removing the equipment pre-hospital if you don't have trained people that you are either sending with the athlete in the emergency room in the ambulance, or there are not properly trained people in the emergency room when they get there upon arrival. The question is, what is the definition of pre-hospital? Most people will agree that equipment should be removed pre-hospital without an escort or without trained people on the receiving end. But what is the definition of pre-hospital? Pre-hospital doesn't mean on the field, before they leave the field. Pre-hospital means before they get to the emergency room. So that's where our decision-making process comes in. Is it most appropriate to remove it on the field before we transport them from the field? Or can we stabilize them, get them on the spine board, get them out of the uncontrolled environment, get them under the tunnel, or get them in the back of the ambulance, get them in a controlled environment, and then remove it there? Neurosurgeons are generally indifferent to the transfer techniques. I mentioned that before. They don't particularly care whether you flat lift or log roll, as long as you are assuming safe handling measures. Most trauma surgeons, however, do, and spine surgeons do prefer the long spine board. So they do actually prefer to receive someone in the emergency room on a long spine board. Some of the arguments for taking equipment off in the pre-hospital setting is based on the fact that we are the experts at removing it, so why shouldn't we be the ones to remove it, rather than sending them to the emergency department where they don't have any experience doing that? I'm sorry to say, but it's an awfully big assumption to assume that all of us are experts at removing equipment. I see some athletic trainers that probably should not be working football because they have no idea how to remove football equipment from an injured player. So to assume that because we have ATC at the end of our name, we are experts at removing that equipment is a very dangerous assumption. So it should be a part of our practice that not only do we have an emergency action plan, but that emergency action plan is practiced and rehearsed. And part of that is all of these techniques that we've been talking about: helmet removal, face mask removal, shoulder pad removal, all that stuff. We should absolutely be the experts at it. But there's no evidence to support we are the experts at it. There's no evidence to support that it's safer to remove it in the hospital or in pre-hospital versus hospital setting. So the EAT implications, and again, allow me, if you will, observations, anecdotal observations that I've made over the last years in teaching the program. Your emergency action plan should facilitate care along the entire continuum. If your emergency action plan stops when the ambulance leaves your field, then your emergency action plan isn't thorough. Your emergency action plan should continue all the way through the continuum of care, all the way till they get to the emergency room, and include initial care in the emergency room if equipment removal is needed, even if that means you go into the emergency department and training them on how to do that, or making provisions for someone who knows how to do that to go along with the athlete. Your emergency action plan, as I alluded to moments ago, you need to have annual training with your emergency action plan. And again, anecdotal observation, you need a minimum of 15 hours annually of emergency action plan rehearsal. Some of this is backed up pretty close anyway. If you look at some of the nursing school and medical training literature, you'll find that in terms of critical care skill practice, it takes pretty close to around that 15 hours of annual preparation and training to maintain critical care skills. So Some of my observations are backed up pretty close by research. But what we found is that you need a minimum of 15 hours of training before you're effective or efficient at any of these procedures that we've been talking about in terms of completing critical care tasks. Your emergency action plan should go under a systematic review. It should include cognitive competence. So not only should you be able to demonstrate the skills, but again, you should be able to cognitively assess what skills are most appropriate at any given time. It should have benchmarkings. Your emergency action plan, when you are rehearsing that emergency action plan, not just can you get the helmet off, but can you get the helmet off in time to complete high-quality CPR and ACLS protocol. And in that should be your performance standards that are based on those benchmarks. If you can't get the face mask off in less than 30 seconds, then you should practice until you can get it off in 30 seconds. If you can't get the equipment off of your athlete in time to complete ACLS benchmarks, then you need to practice until you can. You don't get a pass because they're an equipment-laden athlete. It's your job. You need to practice that until you have the skills to meet the benchmarks. We don't get a pass because they're an equipment-laden athlete. So, and to wrap things up, you got to keep in mind, I think, what athletic trainers bring to the table in this, in terms of sports emergency care. I talked earlier about our dedication and what you learn from experiencing the day that it happens, if you will. But what athletic trainers bring to the table, I saw somebody wearing a shirt at breakfast this morning, actually, that said something to the effect that athletic trainers are like icebergs. Is the guy that's wearing that in here by any chance? All right, maybe you'll see it around. Was that you? All right, so I saw a guy at breakfast this morning. Apparently it's this guy over here. And his T-shirt said, athletic trainers are like icebergs. You only see 10% of what we're actually doing. And that should actually I think that very well states the truth. You only see us taping ankles. You only see us putting on Band-Aids. You only see us running over and giving somebody a roll of tape, taping a piece of equipment back on. That's all that people see, okay? But what they don't see is the other 90%. And the other 90% is the dedication to an emergency action plan. It's practicing the emergency action plan, reviewing it with EMS, and practicing it with EMS behind the scenes in the gym after a full day of watching sports and prepping the teams, and basketball goes till 7:30, it's 9 o'clock, and now you have your EAP review, whatever it is, whatever it takes. That's what people don't see. They don't see the behind the scenes. But it's that behind the scenes that I think makes a difference between having an athletic trainer on the sideline and having another healthcare professional who is acting in our place. That's the difference. It's what we bring to the table. It's what we bring to the sideline. Our primary objectives approach, the red kit philosophy. And I threw on here at the last minute a medical timeout. Has to be built into your emergency action plan, and I put that in red, and I'll conclude with the medical timeout, which is what we should start with. Your emergency action plan should incorporate a medical timeout, at which time, prior to the start of every game, you are talking to the opposing team's medical staff, if they have one. You're reminding your coaching staff, hey, if something goes wrong, here's my emergency signal to let you know you need to bring my emergency stuff out to the field, and we need to activate the emergency action plan. If today is Saturday, this is our critical care triangle. Remember, coach, I'm at A, you two are at B to start. If I give the all-come signal, you're responsible for bringing the red kit and the defibrillator. Okay? The next, maybe it's Friday night. You're going over your medical timeout. You can't assume that your critical care triangle is there. Maybe one of your coaches isn't there for that game. So it's during your medical timeout when all of these things that can trip up your emergency action plan are gone over to make sure that that critical care triangle is in place. We've seen that play out particularly this last year with a number of organizations that we've worked with that have had issues over the last, not now, but last season. And these are teams that have been practicing their emergency action plans for a long time and are very good at what they do. And something as simple as their emergency airway management supplies were in 3 different kits. So they had BLS stuff in one kit, ALS stuff in another kit, and emergency medications in a 3rd kit. And the person that was then, at that particular instance, in a real-life scenario, the person that was told to go get the airway management stuff didn't know which of those 3 kits the stuff they were supposed to get was in. So there was a delay in getting that emergency response equipment to the injured athlete. And that's as simple, that is as simple as a medical timeout saying, here's the airway management stuff, this is where it is. Just to remind everybody of where it is. So I leave you with that the medical timeout should be something that you revisit in your emergency action plan and that you put a lot of work and a lot of time and effort into. Now, what I wanted to do, I have a whole lot of equipment here, actually, that's packed up in the back. I don't know how we can, I wanted to do some demonstration stuff, and I think maybe what I would rather do is this. Let's do some question and answer stuff. If anybody has questions and answers, let's do that. We'll have kind of an open discussion, question and answer thing. And then anybody that wants to stick around, we'll crack those cases over in the back. I've got rescue mannequins back there. I've got helmets, shoulder pads. Anybody that wants to go over some stuff, anybody that wants to practice some things, we can crack those cases open and kind of go over some stuff. So we can do that if you want. If anybody wants to stick around, I'm more than happy to do that. Demonstration stuff, anything along the way. Yeah.
So one of the questions that we have is, would you cut the back of a shoulder pad straps in a conscious, probable cervical injury prior to log roll to help ease removal if the patient is face down?
That's a good question. So the person is alert and responsive?
Yeah.
All right. Person's alert and responsive. No, I would not. I wouldn't actually, I don't think in any scenario would I cut the back of the shoulder pads. And to be honest, if it's an emergency situation, I wouldn't waste the time because there's more critical tasks to complete. If it's a non-emergency situation, I don't think I would because I'm not one to remove all of the equipment in the first place, probably. And second of all, to be honest with you, I don't think it facilitates removal of the equipment. When you use proper removal equipment removal protocols, it's really not that hard to get equipment off. So to take the time to cut and do all of that kind of stuff, I don't think I would do that simply because I don't think it's going to make things that much easier on me when I do make the decision to remove it. I just haven't found it to make that much of a difference. The same goes for helmet removal. Popping the cheek pads out, deflating the air bladders, and all of that kind of stuff, I have not found, and again, anecdotally, observationally, my own opinion, I have not found that to facilitate helmet removal. And with the new helmet technologies that are out there, most of the cheek pads are bolted into the side anyway, and they're not going to come out. Save for the new Riddell Flex custom fit helmet, Riddell did make those cheek pads removable to facilitate helmet removal. But in the the opportunities I've had to deal with that helmet, again, that helmet with proper protocol, that helmet pops right off with no preparation whatsoever. Slides right off.
Okay, next question. Is performing a jaw thrust still the best method in C-spine CPR?
Yeah, yes, absolutely. I always make the statement that there is no room for a head tilt chin lift in athletics. Because if you have unless you see an athlete fall, then we are always going to assume that there's a head and neck injury, especially if in a collision and contact sport. Unless you see that athlete fall and you know it's a collapse and you know there's no mechanism of injury, we're going to make the assumption that that there's going to be a C-spine injury, and we're going to use a modified jaw thrust for that.
Okay. If procedures in the appropriate position statement are not followed and the outcome is not positive, where does the AT find expert witnesses to testify on their behalf in court?
That's a good question. I don't know where you would go to find a database of people that'll line up to help you out, except to say that if you follow those NATA guidelines, and in following those guidelines, you do not follow standardized BLS, American Heart Association chain of survival objectives, you're going to be wrong every single time. It doesn't matter what other document you are following. The gold standard is the chain of survival. If you interrupt that chain of survival, you're going to be wrong. So where do you go to get people to defend you? I don't know. I don't have that answer for you, except that I would much rather be out there trying to find somebody to help defend me for following the chain of survival than I would be I left the chain of survival to follow a different guideline. I would not want to be in a position of trying to find somebody to help me do that.
And about how many times have you actually activated your EAP for cervical spine injuries?
I've activated I've activated it twice for cervical spine injury. One was a football player, a JV football player who was hurt, a visiting team, JV football player that was hurt in the end zone, who was unconscious, face down, and not responding, but his vital signs were fine. We activated the emergency action plan, sent him to the hospital. He came back. It took him a couple hours to wake up in the emergency room, but he did wake up. He was cleared at C-spine. The other was we activated it for a varsity lacrosse player 3 years ago, and I knew he was hurt. There was no question that he was hurt. He had all the clinical signs and symptoms of having a cervical spine injury, and we activated the emergency action plan. And that was an interesting process that we went through. That was a lacrosse player. He actually did come back he had a cervical spine fracture at C5, C6, and with a diagnosed cervical cord contusion. So he had a really good injury, really bad injury, put it that way. He had a really bad injury. The interesting thing there that came up there was that we had a paramedic that was adamant about removing the equipment from him. And at that point, I wasn't so concerned about whether we should remove the equipment or not, but they were adamant that all the equipment needed to be removed on the field before we got him on the gurney and into the ambulance. And I think that's important to bring up, because even though that was a different philosophical approach than I would have taken, I didn't argue with them at that point. And I think that's an important point to bring up in this. If you get EMS that responds and they have a different approach than you, don't argue with them about it on the field. You're not going to win the argument, number one, because they'll always default to EMS protocol. You'll never win that argument. And second of all, in producing the argument, all you're going to do is make everybody around you very anxious. You're going to delay critical care of that athlete. That athlete should just be sent to the hospital. And at the end of the day, whether we remove the equipment or whether we don't, it doesn't really matter. If we remove the equipment from the athlete and we use proper protocols, safe handling protocols to do so, I'll remove. If the paramedic wants to remove the equipment, I'll remove it. Fine. I'm not going to argue. There's just a right way to do it. Yeah.
Changing the liability to us other than EMS, they're saying it doesn't matter. It really does. By allowing them to make that decision, the liability has left me now. I'm not going to get sued if they want to do it, and they can get sued. So I'm just saying it does matter who makes that decision according to the parents and the lawyer. Because even if I do everything perfect, it's never perfect.
Oh, right. Absolutely.
So there's always room to get sued. So if I'm out there stabilizing and he's breathing and I have circulation, and I'm stabilizing, EMS comes out and says, let's remove it. I'm going to say, Coach, you heard that, right?
Yeah.
Okay, let's remove it. Now, my liability has dropped significantly.
Yeah.
I don't know if anybody's been through that, but that's a scary time. When they start bringing lawyers to your door,
Yeah.
that's scary as heck.
Yeah.
So, I mean, from this thing, I still don't know where I stand. I'm going to have to meet with my school board president, my superintendent, and see what they want to do, how they want to do it, because they're all involved in this as well, right?
To be honest with you, no. And from a legal standpoint, when you activate EMS, we really are starting to remove ourselves from the process. When you activate EMS, EMS is taking control of that, especially in an ACLS situation. So,
In my rules, when EMS hits the field, they are in charge. I am only assisting them.
yeah,
That's what I tell all my assistants.
yeah,
When they hit the field, they're in charge. But
Right.
if before I call them out, if I'm taking off the helmet and shoulder pads, don't know if I'm going to do that
yeah.
unless I have to
No,
breathing.
I've lost you there. What are you saying? If you are going,
I'm not going to start removing stuff unless it's an emergency. We're breathing, where circulation's involved. I'm going to stabilize them until EMS gets there. I think that's going to be my program.
yep. I'll tell you what I do. If I know I'm activating EMS and it's not, I'll remove the face mask and then I wait.
Yeah, that's what I do too. Of course, I have EMS at all varsity games, but my middle school games I don't.
Right.
But they're within 3-4 minute response
Right.
time.
Yep. So activate EMS, and then while you're waiting for EMS, you get the face mask off, and you monitor and stabilize and monitor the vital signs, and wait for EMS. Because the reality is, we can fight and argue all we want about that, but the reality is, when EMS shows up, EMS is under the direction of a medical director who is a physician who is going to oversee everything. It doesn't matter what we say at that point. If EMS has been told by the medical director that this is the way they are supposed to respond, you're never going to win the argument. And as far as I'm concerned, am I afraid of getting sued? No, to be honest with you, because if that kid comes back and they have a serious injury and it's debilitating, you're going to be sued, whether you did everything right or not, whether you went along with EMS or whether you argued with EMS. You will be named in the suit. There's no way around that. You were on the field. Everyone from the people that made the paint the lines on the field are going to be named in the suit to initiate that, when it's initiated. But at the end of the day, they're going to have to prove that what you did resulted in the disability, and that's just not going to be very easy to do.
The thing about it I was trying to make a point about was when I was at one school, this happened, only it was not that serious. Okay, but the parent ended up suing all of us. But because we did everything right and we did it according to the rules that I had set up and cleared through the superintendent and through the president of the school board, they supplied me the lawyer. Well, I didn't have to pay for it.
Right.
And if I don't get them involved in it, I'm not sure that they're going to help me like that. So I'm just saying.
Yeah, no, I see what you're saying. No, you have to have them involved in the emergency action plan for sure. Okay. It's got to be an adopted emergency action plan that everybody has agreed on and then that you followed. Absolutely, they have to be involved in it to that point. But they're not going to be involved in your superintendent is not going to be saying, no, I want you to remove the helmet and EMS has to follow this. I mean, that's I'm sorry, I thought that's where you were going with that. Any other questions? Okay, so like I said, I am more than happy and